to the apex. Then, with the bell of the stethoscope, listen again at the mitral and tricuspid areas. Starting in the right second interspace helps orient you to the cardiac cycle. In the second sequence, start with the bell and listen first at the mitral and tricuspid areas. Then change to the diaphragm and, starting in the aortic area, listen to all 5 areas from above down. Starting at the mitral area is useful when you've had to turn the patient to find the apical impulse. The first auscultation sequence is shown in this video.
What I'm going to do now is listen to your heart in the various areas of your chest.
Now adjust your stethoscope so that you'll be listening through the diaphragm. When pressed firmly on the chest, the diaphragm is best for hearing relatively high-pitched sounds, such as S1, S2, the murmurs of aortic and mitral regurgitation, and pericardial friction rubs. Begin listening at the right second interspace close to the sternum. Note the cardiac rate and rhythm. Identify the first and second heart sounds and listen for extra heart sounds and murmurs.
Please breathe deeper than normal.
Then listen at the left second interspace. Try to hear splitting of S2. Here it is abnormally wide. It comes and goes with respiration.
Continue to breathe deep.
Proceed along the left sternal border to the third interspace. Again, listen for splitting of S2.
Welcome to this clinical skills lecture on assessing the jugular venous pressure. This tutorial discusses the ideal method for assessing the jugular venous pulse by covering the following topics. First of all, what is the jugular venous pressure? Patient setup and positioning, locating the jugular venous pressure, measuring the height of the JVP, use of techniques to alter the JVP, the assessment of the waveform of the JVP, and interpretation of the results you then get. The JVP is used to assess the right atrial pressure and to look at the right heart hemodynamics. Consideration needs to be given to the height of the impulse and its waveform. As the JVP varies according to the position of the patient, this needs to be standardized. By convention, the patient should be sitting with their legs flat and their back at an angle of 45 degrees. To allow relaxation of the neck muscles, the patient should have the head supported and turned approximately 30 degrees away from the observer, usually to the left, as the right internal jugular is easier to assess as it is straighter. In order to locate the JVP, its position relative to the other neck structures needs to be clear, and this diagram shows this relationship with the two heads of the sternocleidomastoid and the internal jugular vein passing up between them above the clavicle. To produce a consistent result, the height needs to be compared to a fixed anatomical structure, and by convention the sternal angle is used as the point of reference, as it is at the level of the right atrium. The difference is read in vertical centimetres. side and relax your neck muscles. So you can see the sternocleidomastoid, the two heads here, and obviously the clavicle. We're looking for the point between the two heads of the sternocleidomastoid of the highest impulse, which is here. And now in order to get a standardization, we need to fix it to an anatomical position. And what we're going to use is a manubrosternal angle, which is here. And we're going to look at the distance between the two vertically in centimetres, which will give us the JVP. In this case, it's the normal range between 3 and 5 centimetres. Differentiation between the arterial and venous pulsation can sometimes be difficult. This is assisted by 3 observations. Firstly, the JVP is a bifid waveform in normal health. Secondly, the waveform can be stopped by gentle compression at the base of the neck. And thirdly, the level alters with changes in position and by pressing on the abdomen, which is known as the abdominal jugular reflex. I appreciate that assessing the waveform of the JVP can be very difficult, and it takes a significant amount of practice. That being said, it can provide very valuable information on the condition of the heart. As can be seen in this diagram, normally the waveform is bifid. First of all, you get the effect of the atrial contraction with the A wave, and then later, during ventricular contraction, you get the V wave when the AV valves are shut. The A wave is followed by a descent known as the X descent, and the V wave is followed by the Y descent. All of these can be altered in disease, not least the loss of the A wave in the presence of atrial fibrillation. Assessing variation from the normal pattern can be considered both in terms of the height of the JVP and its waveform. Normally, the height of the JVP is no more than 4 centimetres above the sternal angle, which equates to a 9 centimetre right atrial pressure. Be careful, as at times the JVP can be so high that it's difficult to appreciate as it's up above the ears. Examples of alteration in the waveform occur in various situations. In pulmonary hypertension, you get accentuation of the A wave, and this will lead to a very large and marked X descent. In tricuspid regurgitation, you get the regurgitant wave connecting together the C point and the V wave, giving you a so-called CV wave. And in right ventricular constriction, you get a very steep Y descent, as shown here. I hope you've enjoyed this tutorial and learned from it. Further information on the variations in the JVP waveform can be found in standard texts.
You examine the jugular venous pressure by examining the jugular venous pulsations. The jugular venous pulsation indicates the right atrial pressure. In a normal person, when you put the patient at 45 degrees using a backrest, the jugular venous pulsation in a normal person with normal right atrial pressure comes just at the clavicle. In case you put a patient at 45 degrees and you get to see the jugular venous pulsation in the neck, that means the jugular venous pressure is raised, like we have done here. So you incline the patient at 45-degree angle and look for the pulsation. The jugular venous pulsations would occur on the lateral aspect of the sternomastoid. These are multiple pulsations called A, C and V positive waves. X and Y are the negative descents. As you could see here, the multiple pulsations of the JVP. Now this patient has COPD and emphysematous chest, which is causing raised jugular venous pressure. Now this is demonstration of the hepatojugular reflux, which again is a sign of right heart failure. Now what is done? We see the position of the jugular venous pulsation. Why hilo mat itna, haath seedha karke rakho. You see the jugular venous pulsation. Now exert pressure on the right hypochondrium. The jugular venous pressure will rise. Okay, the next vein will become more engorged. See. See, on pressure on the right hypochondrium, the jugular venous pressure has risen. The pulsation has disappeared, it has gone up. Now on releasing, see, it will reappear. So this is because the right atrium is not able to clear the increased venous return that occurs on pressure on the right hypochondrium, which is increased venous return from the liver. Because the right heart is failing, so it cannot accommodate the extra blood, therefore the JVP rises.